Welcome back to the Deep Dive. Today we're tackling something a bit strange, maybe even alarming, that feeling people often just call tooth numbness. You know, if you've ever had dental work, you probably know that feeling where your lip feels like a block of rubber for a few hours. But what if that feeling, that tingling or maybe complete lack of sensation, shows up unexpectedly? Or what if it just lingers way too long?
Yeah, tooth numbness isn't exactly a formal medical term you'll find easily, but it's a really common way people describe a whole bunch of confusing symptoms. So our mission today is to cut through that confusion. We want to get past the everyday description and really dive into the clinical side of things. We're talking about paresthesia affecting the teeth and jaws. And this gets into some pretty deep anatomical territory. It covers everything from temporary stuff to potentially serious nerve issues.
And we absolutely have to start with the basic physiology here, because this is where the common understanding often goes a little bit wrong. Your teeth themselves, well, they don't actually have the kind of nerves that sense numbness like your skin does. The pulp, that's the nerve tissue deep inside the tooth, it's really only built to sense big things: pain, significant temperature changes, maybe pressure, not fine touch or numbness.
Okay. So if you feel like your tooth is numb or dead, it's not like the nerve inside just, nodded off for a bit.
Exactly. It's usually a sign of something more significant happening. When someone says they feel numbness just in one tooth, it generally points to one of two main things. Either the nerve inside that specific tooth is actually dead, so it's non-functioning, or maybe it's even gone, or the sensation isn't coming from the tooth at all. It's being referred from the tissues around it, the gums, the jawbone, or potentially a larger nerve trunk supplying that whole area.
And figuring out which one it is sounds pretty critical, because that second option sounds like it could point to much wider nerve trouble.
It definitely could. Distinguishing between a dead pulp and damage to a major nerve branch is job number one.
Okay, let's unpack this. Maybe start with the most familiar one, the temporary, totally expected cause, the injection.
Right, the dental freezing, that's definitely the easiest place to begin. Local anesthetics, things like lidocaine, articaine, they're by far the most common reason for temporary numbness. I mean, we expect it, we plan for it. It's essential for comfortable treatment.
And how they work is actually quite neat, isn't it? They don't just muffle the pain signal. They physically stop the nerve from sending any signal.
Precisely. They target something called voltage-gated sodium channels in the nerve fibers. Think of these channels as little gates that the nerve's electrical impulse needs to open to travel along. The anesthetic basically jams those gates shut. So the electrical impulse just hits a wall. It can't get through. Stops pain signals, yes, but also blocks the nerves carrying touch and pressure information. That's why your lip or cheek feels so thick and unresponsive.
Right. And I know articaine is often used because it gets into the nerve a bit faster. Affects those channels quicker.
Yeah, it's a bit more lipid soluble, so it penetrates the nerve sheath more effectively. That can mean a faster onset, maybe slightly different duration. Usually we're talking 1 to 4 hours, roughly.
Okay, so 4 hours pass, the drug wears off, feeling comes back. Normal. But what if it doesn't come back properly, or it changes into something weird like painful tingling? That's when we start talking about physical trauma, right?
Exactly. This is the shift from a temporary chemical block to actual physical damage to the nerve itself. The key structure involved here is the neurovascular bundle. It's this tiny little lifeline of nerve tissue and blood vessels that enters the tooth right at the tip of the root, the apex.
Okay, so that bundle is what keeps the tooth alive and feeling things.
It's literally the tooth's connection to the body's nerve and blood supply. Enters through a tiny opening at the root tip, feeds the pulp, provides sensation. Now, if you have trauma, that bundle can get sheared or crushed or torn. Think about a luxation injury. That's when a tooth gets knocked hard, maybe pushed deeper into the socket or shifted sideways. That sudden movement can easily sever that delicate nerve and blood supply right at the apex. The result? Pulp necrosis. The nerve dies. Often there's intense pain right at first, but then it might be followed by this really odd feeling of the tooth just being, well, dead or numb.
Or think about a bad tooth fracture. I imagine if it breaks right into the pulp, that initial pain must be horrific.
Oh, excruciating. When the fracture exposes the nerve directly, it's agony. But then, if that exposure leads to the nerve dying off completely, that intense pain can be replaced by just nothingness. And that sudden relief isn't good news. It's actually a really worrying sign that the pulp hasn't survived.
And this trauma doesn't have to be just the tooth itself, right? Like a broken jaw.
Absolutely. A fracture of the lower jaw, the mandible, is particularly concerning because of the inferior alveolar nerve, or EAN. This is a major nerve trunk that runs right through a canal inside the lower jawbone, supplying feeling to all the lower teeth, the lower lip, and the chin on that side. If the jaw breaks near that canal, the nerve can get easily crushed or even severed by the bone fragments. The result is often immediate, widespread numbness, paresthesia affecting all those areas. It's a serious injury, needs urgent attention.
Okay, now this is where things get maybe even more relevant for a lot of people. Let's talk about numbness that happens after planned dental work. Wisdom teeth seem to be the classic example here. You hear stories about numbness lasting for ages after getting lower wisdom teeth out.
Yes, extracting lower wisdom teeth is definitely a key procedure associated with potential nerve injury. The anatomy down there is just tricky. You've got two major nerves really close to where those wisdom teeth often sit. There's the inferior alveolar nerve we just talked about, often lying right beneath or sometimes even looping around the roots. And then there's the lingual nerve, which gives sensation to your tongue, and it runs along the inside edge of the jaw near the wisdom tooth area too.
So during the surgery, those nerves are just vulnerable.
They really are. Depending on how impacted the tooth is, how deep the roots go, the nerve can get stretched or bruised. That's a temporary injury called neuropraxia, where the nerve signal is blocked but the nerve structure is intact. Or if things are more difficult, maybe the tooth needs to be sectioned or elevated with some force, the nerve could potentially be crushed or, very rarely, even cut.
Are there numbers on how often this happens?
Yeah, the data suggests temporary nerve injury. The bruising or stretching happens in maybe 0.5% up to around 8% of lower wisdom tooth cases. That's quite a range, and it depends a lot on the difficulty. Permanent injury is much rarer, thankfully. We're talking maybe 0.01% to 1%, but obviously for that small percentage of patients who experience permanent numbness, it's a devastating complication.
Okay, let's switch gears slightly. What about a type of numbness that's actually the goal of a procedure, like after a root canal?
Right, that's a great point. With endodontic therapy or a root canal, the whole point is to deal with an irreversibly infected or inflamed pulp. So we intentionally go in, clean out, and completely remove all that pulp tissue, the nerve and blood vessels from inside the tooth. Once that nerve tissue is gone, the tooth physically cannot feel hot, cold, or pain from decay anymore. And patients often perceive this as the tooth feeling numb or dead, which in a way it is internally.
But you mentioned earlier that the tooth isn't completely dead to sensation even after a root canal.
Yes, that's the crucial distinction we touched on. While the internal pulp nerve is gone, the tooth is still anchored in the jaw socket by the periodontal ligament, or PDL. This ligament is full of its own sensory nerves, primarily for pressure and position sense. So even with no pulp, you can still feel pressure on that tooth when you bite or chew. That PDL sensation is what stops you from biting down way too hard on a root canal tooth. It still gives your brain feedback.
That makes a lot of sense. It's still connected, just differently. Now, within root canals, is there a way things can go wrong and cause unwanted numbness?
Yes, there is an iatrogenic risk, meaning caused by the treatment itself. It's relatively uncommon, but it happens. We call it an overfill or extrusion. If the root canal sealing material, like the cement or gutta percha, gets pushed out beyond the very tip of the root, it can end up in the surrounding jawbone. And if that root tip is very close to the inferior alveolar nerve canal, that extruded material can physically press on or chemically irritate the nerve, causing paresthesia, numbness, or tingling in the lip and chin.
And I guess that same risk applies when placing dental implants in the lower jaw too, hitting that nerves.
Absolutely. Placing implants in the back part of the lower jaw always involves navigating around that inferior alveolar nerve canal. You need enough implant length for stability, but you absolutely cannot encroach on that nerve space. This is precisely why careful preoperative planning with 3D imaging is so essential. It's not just recommended, it's really the standard of care now.
You mean like a CBCT scan? What does that show you that a regular flat X-ray doesn't?
Exactly. Cone beam computed tomography. A standard 2D panoramic X-ray shows you height and width, but it flattens everything out. You can't accurately judge the depth or the exact 3D position of the nerve canal relative to where you want to place the implant. The CBCT gives us cross-sectional slices like a mini CAT scan of the jaw. We can map the nerve's path precisely, measure the bone width, and determine exactly how much vertical space we have between the planned implant tip and the top of that nerve canal, down to the millimeter. It drastically reduces the risk of accidentally impinging on or damaging the nerve during placement.
Okay, so shifting perspective a bit. Sometimes that numbness or tingling feeling in the jaw or teeth area isn't directly related to a tooth problem or recent dental work at all. Sometimes it's actually a signpost pointing towards a much bigger systemic health issue or a broader neurological condition.
Right. This is where oral health connects to the whole body. So what are the major neurological pathways we should be aware of here? Well, the big one is the trigeminal nerve. That's cranial nerve number 5. It's like the sensory superhighway for pretty much the entire face, including the mouth, teeth, and jaws. So if something disrupts that nerve pathway higher up, closer to the brain, it can cause numbness in the areas it supplies, like the jaw or lip. We're talking potentially serious underlying conditions here. Things like multiple sclerosis, which damages the protective myelin sheath around nerves, or a stroke affecting the brain regions that process facial sensation, or even sometimes a slow-growing brain tumor pressing on the trigeminal nerve root.
Wow, okay, that's definitely a huge step up in seriousness from, say, a bruised nerve after a wisdom tooth extraction.
It absolutely is, and that's why unexplained persistent facial numbness always warrants a thorough investigation. It could be a red flag for something significant. And then there's also peripheral neuropathy. This is more about nerve damage happening more widely throughout the body, often affecting the extremities like hands and feet first. But sometimes the earliest symptoms might actually show up in the mouth, maybe a burning sensation or that pins and needles feeling in the lips, tongue, or even gums.
And what kind of diseases typically cause that widespread nerve damage?
Probably the most common systemic cause is diabetes mellitus. Over time, high blood sugar levels damage the tiny blood vessels, the microvasculature, that nourish the nerves. When nerves don't get enough blood supply, they start to malfunction, leading to neuropathy symptoms like tingling or numbness. Other important ones to consider are severe vitamin B12 deficiency. B12 is crucial for nerve health, and sometimes hypothyroidism, an underactive thyroid gland. Both can present with oral paresthesia as a potential symptom.
Okay, let's swing back to more localized issues for a moment. Can a simple infection sometimes feel like numbness, even if the nerve itself isn't dead or directly injured?
Yes, definitely. Think about a severe dental abscess. That's a pocket of infection, usually at the root tip of a tooth. This infection causes significant inflammation and swelling within the jawbone. All that pressure building up can physically compress nearby nerve endings. So even if the main nerve trunk is fine, the localized pressure can make the area feel numb or altered. And that needs immediate treatment, usually draining the infection via root canal or extraction, plus antibiotics to relieve that pressure.
And what about sinuses? I know people sometimes feel weird sensations in their upper teeth when they have a bad sinus infection.
That's a classic example of referred sensation due to proximity. The roots of your upper back teeth, especially the molars and premolars, often sit right next to, or sometimes even slightly protrude into, the maxillary sinus floor. So if you get severe sinusitis, a major sinus infection with lots of inflammation and pressure buildup in that sinus cavity, it can press on those nearby dental nerve endings. Patients might report a dull ache in their upper teeth, or sometimes, even a feeling of numbness or fullness in that area, all referred from the sinus inflammation.
Okay, so there's a whole range of possibilities. Let's say someone comes to you with this persistent numbness. What's the step-by-step process? How do you figure out if it's a dead tooth, a compressed nerve, or maybe one of those systemic issues?
The diagnostic journey starts always with a really thorough patient history. When did the numbness start? Was it sudden, or did it come on gradually? Crucially, did it follow any dental procedure, any trauma, or maybe a recent illness? What's their overall medical background? Then we move to the clinical examination, focusing on the tooth or teeth in question. And a key part of that is vitality testing.
Right, trying to see if the nerve inside the tooth is actually alive and responsive.
Exactly. We need to know if the pulp is vital or non-vital. We typically use a cold test, applying something very cold, like a refrigerated spray on a cotton pellet, to the tooth. A healthy pulp will react strongly, usually with a sharp, brief sensation. We might also use an electric pulp tester, or EPT, which sends a mild electric current through the tooth to stimulate the nerve. If the tooth doesn't respond at all to either of these tests, especially compared to neighboring teeth, that's a strong indicator that the pulp is non-vital or dead. That immediately tells us the numbness likely originates from inside that tooth. It's a localized pulp issue.
And imaging must play a big role too, especially if trauma or surgery was involved.
Indispensable. Standard periapical x-rays, the little ones we take inside the mouth, are good for spotting obvious things like large abscesses or clear fractures. But for anything more subtle, or especially when we suspect involvement of a major nerve like the EN, or need to assess complex root anatomy, that CBCT scan we talked about is invaluable. That 3D view can reveal tiny fractures that 2D x-rays might miss entirely. And as we discussed, it lets us precisely map the relationship between tooth roots, surgical sites, and critical nerve pathways.
So once you've managed to pin down the cause, dead pulp, bruised nerve, infection pressure, systemic issue, the treatment obviously has to match that specific cause, right? You can't just treat the symptom of numbness.
That is absolutely the core principle. Treatment is entirely driven by the underlying diagnosis. So if the numbness is just the lingering effect of local anesthetic, the treatment is simple. Patience. Wait for it to wear off. If it's a minor nerve injury from surgery, like that neuropraxia, just bruising or stretching without severing the nerve, often the best approach initially is careful monitoring. The body has a remarkable ability to heal the nerve's outer myelin sheath over weeks or sometimes months. Patience and observation are key there.
But are there things you could do actively to help that healing process along or reduce inflammation right after an injury?
Yes, definitely. If nerve injury is suspected immediately after a procedure, like wisdom tooth surgery, starting a course of high-dose corticosteroids like prednisone can be really beneficial. Steroids are powerful anti-inflammatories. They reduce swelling around the nerve, which can relieve pressure and potentially improve the chances of recovery. We also often recommend supportive measures. Things like a vitamin B complex supplement and maybe alpha-lipoic acid are thought to potentially support nerve health and metabolism during recovery, though the evidence varies.
And if the numbness is clearly from infection pressure, like that abscess?
And the solution is direct. Eliminate the source of the pressure. That means either performing root canal therapy to clean out the infected tooth or extracting the tooth entirely, plus antibiotics to clear the infection. Similarly, if it's sinusitis causing referred numbness, treating the sinus infection with decongestants, maybe antibiotics if it's bacterial, should resolve the dental symptoms as the sinus pressure goes down.
Okay, but what about those more worrying cases where the numbness doesn't get better? Say it persists for months after an injury, like 3, maybe 6 months, with no improvement.
Right. If significant paresthesia persists beyond that kind of time frame, roughly 3 to 6 months, and isn't showing signs of spontaneous recovery, then more advanced intervention might be considered. This usually falls into the realm of specialized oral and maxillofacial surgeons. We're talking about microsurgery aimed at nerve decompression or repair. The surgeon would actually go in, surgically explore the nerve site, carefully remove any scar tissue that might be constricting the nerve, essentially freeing it up. In more severe cases, if the nerve was actually severed, they might attempt a repair, possibly even using a nerve graft to bridge the gap and try to restore some continuity. These are complex procedures with variable success rates.
And finally, if that whole diagnostic process pointed away from the mouth entirely, towards something systemic like diabetes or MS gut,
then the management shifts completely. It becomes a multidisciplinary effort, primarily led by the patient's physician, or perhaps a neurologist. The focus has to be on managing the underlying systemic condition, controlling blood sugar levels in diabetes, managing the autoimmune disease in MS, correcting the B12 deficiency, and so on. The dentist's role in those cases is mainly diagnostic, recognizing the potential link and making the appropriate medical referral. We treat the mouth, but medicine has to treat the underlying disease causing the neuropathy. So really, to bring it all together for you listening, that feeling of tooth numbness is definitely not just one single thing. Think of it more like an alarm bell. The absolute most critical distinction to make is whether that sensation is truly localized to one specific tooth that's likely non-vital, which is usually manageable with standard dental treatment like a root canal or extraction. Or is it a broader numbness, a paresthesia maybe affecting your lip, your chin, your tongue? Because that pattern suggests potential physical damage to a larger nerve trunk, or maybe even points to one of those serious systemic conditions we discussed. And that requires much more urgent investigation and potentially medical referral.
Yeah, the takeaway really seems to be, don't ignore persistent numbness, whether it feels like tingling, burning, or just a complete lack of feeling, especially if it shows up after some kind of facial injury or dental work. You really need to get it checked out professionally. Getting the right diagnosis quickly seems absolutely key. You need to know if you're dealing with just a dead tooth nerve or potentially damage to a major nerve supplying a whole section of your face.
And this whole discussion brings up a really interesting final thought, doesn't it? We've talked a lot about what happens when the nerve inside the tooth, the pulp, dies either from trauma or because we remove it in a root canal. But even after that internal nerve is gone, the tooth isn't completely disconnected from your sensory system. It can still send signals when you chew, right? Thanks to that periodontal ligament surrounding the root. So consider what that actually means. You can have a tooth that's technically devitalized, no living pulp inside, yet it's still actively providing your brain with crucial feedback about pressure and bite force every time you eat. It really highlights this complex sort of dual sensing system in our mouths, where that ligament becomes just as important for everyday function in some ways as the original pulp nerve ever was. It's quite remarkable, really.